OPD-3 is a wonderful technology for premium patients. The wealth of information that is collected in a few seconds can really help determine if a patient is a good candidate for IOL implantation. With one of the maps we can look at is the size of the pupil. A lot of people forget to look at the pupil size, and that is an important factor when it comes to premium IOL implantation. So that picture of a pupil with angle kappa included really reminds you of the patient's size of the pupil. And so you've got two pieces of information who are very important looking at this patient and whether they're a candidate. You look at pupil size and you look at the angle kappa, and you can determine if patient would be a good candidate for premium IOL implantation. Another nice piece of information is also that OPD is a corneal aberrometer, as it is an aberrometer of the entire eye. And so you can look at and see if the patient's corneas are irregular, and to what extent they're irregular, whether or not these patients become good candidates for premium IOL implantation. So all these pieces of information can help us show patients how they're going to do with the premium IOL and if they are good candidates. So this is where I found the OPD truly fascinating. As we all know, we can use different methods to calculate IOL power after refractive surgery. All of these methods have been proven to be less than ideal, and the fact that we still don't have a method just shows that we do not have a great way of calculating that central corneal power for post-refractive patients. In my experience, what I have found is that the ECCP, the estimated central corneal power, the number that we derive from the OPD, is a very, very useful number to use for patients in post-refractive cases. And many times, if I have no other information, no historical data, I use that number frequently to plug into the formulas and to derive the IOL calculation. I have found that to be a very accurate way of determining the central corneal power in post-refractive patients. The asphericity is a very important concept, and we're just beginning to understand the significance of it. We know that a negative spherical aberration actually adds to the depth of focus for patients and increases their ability to be able to see at near. We also know that positive spherical aberration is not good, and increasing that aberration can actually defocus patients and decrease their contrast sensitivity. In our practice, we use the OPD to customize the aspheric lens to each patient. The reading we get from the OPD we use to determine which implant is best for each patient. So we may use an implant that is spherically neutral for patients who do not have a lot of positive spherical aberration, or we may use an implant that has a high negative asphericity for patients who have a lot of positive spherical aberration to try to neutralize that. So every patient gets a customized implant for that, for their amount of spherical aberrations. An interesting case that I can share with you is that we had a patient recently who presented with a nicely implanted IOL with a best corrected 20/20 vision, who was very unhappy. And she was not a premium IOL patient, but she was still very unhappy. We went to the OPD and realized that she has been implanted with a negative spherical aberration lens of the highest power, and her negative spherical aberrations were extremely high. They were over -0.6. This patient obviously had high negative spherical aberration before surgery, and then the implant added more negative asphericity to her cornea. And so although negative asphericity is a good thing in most cases, it does contribute to loss of contrast sensitivity, and as it did in this patient who was very unhappy. So I was able to come to this patient and tell her what the reason for her problems was, even though she was correctable to 20/20. She was offered IOL exchange, which she declined. However, she was able to understand why she was having the problem that she was having. Well, I think the OPD scan is a wonderful tool, especially for patients who have had multifocal implants. I have certainly, as any other surgeon, have had a patient with an outcome that is less than ideal. I can think of specifically one patient who, after his surgery with an uncorrected vision of 20/25 J1, nicely done surgery with a nicely centered implant, and was still unhappy. So we went back and started looking at what could be the cause. We looked at the posterior chamber implant, and it was clear with a minimal posterior capsular fibrosis. And we also looked at the cornea, and everything was fine. So we went back to the OPD. We noticed his preoperative measurements were very normal. His cornea was clear. He was a good candidate. That was the case at 1 week postoperatively as well. And then we looked at the OPD, and the nice thing about OPD is that it really splits your aberrations into the cornea and the posterior segment, the internal OPD. And this is where it becomes really important. It is truly an aberrometer of the entire eye. And when we looked at his posterior or the internal OPD, we noticed that there were quite a few aberrations there. They were still less than before surgery, but it was very clear that the aberrations were coming from there. So we assumed that the aberrations were most likely coming from his minimal posterior capsular fibrosis, but we weren't sure. So we were able to convince him to wait a little bit and remeasure those aberrations in a few weeks. In a few weeks, those aberrations increased, and indeed we then knew that the aberrations were coming from the posterior capsular fibrosis and not from the lens. And we were able to reassure the patient and explain to him that with a simple laser procedure, he will be able to help him improve his visual outcome and do not need to worry about possibly explanting the implant. OPD-3 has been great because with a click of a button you can gather so much information in patients getting ready for cataract surgery. So the OPD-3 makes our flow much more efficient. If you were to take a patient who's having cataract surgery and getting their measurements done and take him through a machine that does topography and then does aberrations and that then measures the pupil size, the patient would be getting at least 3 or 4 scans, which would take quite a few minutes, possibly 15 to 20 minutes, versus a quick scan, which takes literally seconds to perform. Patients are also very impressed when we can show them how thoroughly we can look at their eye. Specifically, we can show them what their vision is going to be after surgery if they're getting a toric IOL and after surgery even with a regular IOL. They're able to better understand their options and better realize what their potential with their vision can be. Well, OPD-Scan III is a wonderful technology nowadays to show patients and help them understand why they require certain technology or maybe not candidates for certain technology. Everybody comes in expecting wonderful results, and sometimes patients are not good candidates for certain surgical procedures. The OPD can really show the patients with pictures and easy to see demonstrations of what they can expect and why they're not candidates for certain things. For example, I can take a patient and show them why they are a great candidate for a toric lens with the defocus map. And I can show them what their vision is going to be after surgery if we implant a standard IOL versus if we implant a toric IOL. And that simple picture of seeing that with a clear focus can really convince patients to proceed with a toric IOL versus a monofocal IOL. Technicians as well have been very accepting of this technology because it is such an easy system to use. It gives a wealth of information in a matter of seconds. And when these patients come through, a lot of them are elderly and cannot sit and hold still for a long time. OPD can give a lot of information in just one click of a button, and technicians love this technology. It is also a great autorefractor. So when our Marco refraction systems get backed up, as they often do, we can use OPD as a simple autorefractor, which can get technicians started and proceed from there. Well, prior to OPD, in our toric patients, in their postoperative day 7, we used to dilate these patients and check their alignment of the toric IOL with the dilation. Sometimes be easier done because these patients sometimes don't dilate very well, and then they had to sit there for 45 minutes to get their pupils dilated. Nowadays, I can take the OPD and scan these patients even on postoperative day 1, and I can already tell whether their implant is aligned simply by looking at the internal OPD. This is a great tool to where we don't have to dilate these patients. We can send them back to their referral doctor faster and do not have to bring them back 7 days to do the dilation and check the alignment of the lens. Another way that OPD has been very useful is in patients who are getting multifocal implants. We now look at the angle kappa of these patients, look at their pupil size, and look at where their aberrations are coming from. The nice thing with the OPD is that it really splits up the cornea and the internal portions of the eye and lets you know where their aberrations are coming from and whether or not they're going to do well with a premium IOL.